In what essentially involves inflicting fatal injuries in such an environment where this is not the case, surgery is a feat that deals with the thin line between life and death. Part of what makes a surgical team successful is effective communication between each of its members. Before diving into the jargon that surgeons use daily, it is handy to know what surgery actually entails. Surgery is generally defined as the treatment of injuries or disorders of the body by incision or manipulation, especially with instruments. There is, however, a difference between a procedure and surgery. This difference is that surgery involves cutting into or closing tissue or a previously sustained wound and is thus always invasive. There are some exceptions to this rule, namely non-invasive or minimally invasive procedures such as angioplasty or endoscopy. However, these are considered surgical as they occur in surgical settings and require a similar surgical procedure, such as a sterile environment and anaesthesia. Surgery can be on organs, organ systems, and tissues, and for diagnostic or therapeutic reasons. The surgical team comprises an extensive group of people, the first of whom is the consultant surgeon. The consultant surgeon undertakes the overall responsibility for the workings of the multidisciplinary team and will have at least one or often multiple surgical assistants. This may be an associate specialist surgeon, also called a fellow, a surgical registrar, also known as a specialty surgical trainee, core surgical trainee, foundation doctor, or even, on rare occasions, a medical student. These surgeons work alongside one or more anaesthetists and theatre nurses, operating department practitioners, physiotherapists, and other relevant non-surgical specialists. Operating department practitioners, or ODPs, are involved in all aspects of the patient's surgical care during the anaesthetic, surgical, and recovery phases and are vital to a patient's medical care. One essential aspect of any surgical procedure is the distinct separation of sterile and unsterile things, referred to as aseptic technique. This is used to avoid disease-causing microorganisms found on healthcare workers' hands, which may pose a threat to the patient on the table, though would be otherwise harmless. This practice also applies to the surgical instruments used in an operation and the surgical staff's attire. If either of these becomes contaminated by being mishandled or leaving the sterile field, they must be replaced or re-sterilized immediately. Every surgery includes a pre-operative, intraoperative, and post-operative phase. In the pre-operative phase, a patient examination is conducted. Pre-operative tests may be sent for, and the patient's physical status is assessed. This assessment is based on the ASA Physical Status 6-category classification system. A patient in Category 1 is entirely healthy, a Category 2 patient is experiencing mild systemic disease, and in Category 3, severe systemic illness. Type 4 indicates a severe systemic disease that is a constant threat to life. Category 5 means that the person is at the point of death and is likely to die without the operation. The final category, Category 6, refers to a declared brain dead patient whose organs are being removed for donation. Each of these numbers may be followed by an E for an emergency case, e.g. 3E, which is defined as when a delay in treatment would significantly increase the threat to a patient's life or body part. This is used somewhat interchangeably with categories 4 and 5. Preoperative care specific to the particular procedure may include an autologous blood donation, i.e. from the patient themselves, a few weeks before the operation if there is a significant risk of bleeding. Where the digestive system is concerned, a bowel prep of polyethylene glycol may be administered the night before to irrigate the bowel and add electrolytes. Any patient undergoing general anaesthesia will almost always be given an NPO, which stands for nil per os order, demanding nothing be taken by mouth after midnight the night before due to the risk of vomiting during surgery and subsequent aspiration. Routine imaging or tests may also be performed, such as a full blood count, basic metabolic panel, clotting tests, or urinalysis, but these are generally advised against unless indicated due to the danger of misdiagnosis or overtreatment. After a patient has been admitted before their operation, the procedure will be confirmed. The medical team will double-check tests and exams for indications and contraindications, their vital signs are recorded, and a peripheral IV line placed. Preoperative medications like antibiotics or sedatives may be administered, and the hair at the operating site is removed. The skin surface and operative field are sterilized with the antiseptic chlorhexidine gluconate, which is also used to sterilize the surgical team's hands and instruments. There is strong evidence that chlorhexidine is twice as effective as povidone iodine, also known as betadine, which is recognized by its distinct orange color. The patient is appropriately positioned depending on both access to the surgical site and physiological factors like circulation and breathing. Sterile drapes are placed, accommodating for the anaesthetist's unsterile working area by raising the drapes and clipping them to the poles above the head of the bed. At the beginning of the intraoperative phase, anesthesia is then administered. When a patient undergoes local and spinal anesthesia, they are usually awake or minimally sedated. Under general anaesthesia, the patient is intubated and placed on mechanical ventilation. In the post-operative phase, the patient is transferred to the post-anesthesia care unit, known as a PACU, until they are deemed to have recovered from the anesthesia. The patient is checked for post-operative complications and infection, and post-operative therapy may sometimes be required, such as chemotherapy or immunosuppressants. While this summarizes what each phase of surgery actually entails, there are many ways that a surgery can be classified. Firstly, it can be classified depending on its location. Inpatient surgery occurs in a hospital setting where the patient will remain for at least one night afterwards. In contrast, outpatient surgery occurs in an outpatient department where the patient can be discharged the same day. The timing of a surgical procedure is also a key identifier. Elective surgery is that which aims to treat a non-life-threatening condition at the patient's request. A procedure is semi-elective if it involves a life-threatening condition carried out at the patient's request or aiming to avoid permanent disability that can be postponed briefly. Emergency surgery seeks to prevent immediate death, disability, or loss of limbs and functions. Surgery can also be grouped depending on its purpose. Exploratory procedures are used to aid, confirm, and treat a diagnosis. Therapeutic surgery attempts to treat a condition previously diagnosed, and cosmetic surgery involves altering the appearance of a particular structure that is otherwise healthy. If a specific operation uses equipment that is considered unique to that surgery, then this may also be specified, such as in laser surgery, microsurgery, robotic surgery, and hypnosurgery. One of the most common ways of classifying a procedure is by its type. Amputation involves the complete cutting off and removal of a limb or digit. Resection describes the complete removal of an entire internal organ or an essential named part, such as a lung lobe or liver quadrant. Excision refers to removing a localized region of an organ or tissue, and extirpation is the excision or surgical destruction of a body part. Replantation involves the reattachment of a severed body part, and reconstruction is concerned with rebuilding an injured, mutilated, or deformed body part. During transplant surgery, a body part is transferred and replaced from one human or animal to another. Finally, debridement refers to removing dead, damaged, or infected tissue, usually arising from wounds, burns, or infections. Surgery, in general, is also grouped by the body part or parts it applies to. This can be an organ, as in cardiac surgery, an organ system, as in gastrointestinal surgery, or a type of tissue, as in orthopedic surgery. The invasiveness of a procedure may also be included in its name. A minimally invasive or laparoscopic procedure uses specialized miniature instruments inserted into a body cavity or structure through a small incision. This also includes angioplasty. On the other hand, open surgery requires a larger, more accessible incision. It may also be described as either partial or total, depending on the extent of the procedure. Another frequently used method of describing a surgical procedure is based on its anatomical location. There are three anatomical planes, or views in radiological terms, at 90 degrees to one another. These are the transverse, frontal, and sagittal planes. The transverse plane sweeps from the head to the feet and divides the body into upper and lower sections. The frontal plane moves from the front of the body to the back, and the sagittal view sweeps from the left to the right of the body. Many prepositions can be used to describe a particular anatomical location, each with a specific plane in mind. Anterior means at or near the front of the body, and posterior means at or near the back of the body, both in the frontal view. In the transverse view, superior denotes a region towards the head or upper body, and inferior towards the feet or lower body. Medial means nearer to the midline, and lateral means farther from the midline, referring to the sagittal plane. Other prepositions not associated with a particular plane include superficial, meaning close to the surface of the body, and deep, meaning away from the body's surface. Proximal refers to a region nearer to a particular structure's origin, whereas distal means farther from the source of a specific structure. There are two ways that surgical procedures can be named, the most common of which is the classical method of naming. Procedures named in this way contain prefixes and suffixes. The prefix usually indicates the relevant body part, and the suffix refers to the type of procedure being performed. Further description may also be implemented as an exploratory laparotomy. There are prefixes for every structure or formation in the body, some of which are more obvious, such as thyroidectomy. However, some others are commonly used and do not follow such a simple pattern. These exceptions usually take after the Greek names of the body part or parts being referred to. It is helpful to note that these prefixes can be used not only for referring to surgical procedures, but also for their respective diseases, such as arthrotomy and arthritis. Firstly, let's go through some of these prefixes. In neurosurgery, encephal refers to the brain, cranio refers to the skull, spondyle refers to the vertebrae, and lobo refers to a lobe. either of the brain, liver, or lungs. Angio means related to a blood vessel, and thoraco means related to the chest, which, for example, may be used during a cardiothoracic procedure. As might be used in general surgery, colono refers to the large intestine, gastr refers to the stomach, hepat refers to the liver, and lapar or cilio refers to the abdominal cavity. Mammo or masto means related to the breasts, and rhino means related to the nose. Arth refers to a joint, myo refers to muscle tissue, and osteo refers to bone tissue, all of which might be used by orthopedic surgeons. In urology, colpo refers to the vagina, cysto refers to the bladder, cholecysto refers to the gallbladder, and hyster refers to the uterus, and oophor refers to the ovary. Salpingo refers to the fallopian tubes, nephro refers to the kidney, orchid refers to the testicles, and vas refers to a duct, usually the vas deferens. All we need now to fully name a procedure is the suffixes, which, as a reminder, relate to the type of operation being performed. Otomy refers to a surgical incision, ectomy refers to surgical removal or resection, opsy means looking at, and oscopy means viewing of, usually with a scope. Ostomy refers to the surgical creation of a new hole, known as a stoma, plasty refers to surgical reshaping or repair, and synthesis means surgical puncture, usually to draw fluid or air. Tripsy means breaking up, classis means surgical fracture, pexy means securing, and rhopathy refers to strengthening, usually with suture. Desis refers to the fusion of two parts, lysis means separation, osis refers to a process and is therefore typically non-surgical, and finally plication refers to folding. Combining these prefixes and suffixes will thus give us the name of our procedure, such as laparotomy or colonoscopy. The second method of naming uses the name of the surgeon or surgeons that first performed or noted the surgery, as opposed to after the procedure itself. They may also be named after a later surgeon who refined the technique, or in some instances, the first patient that underwent it. All of these procedures are referred to as eponymous. One of the most notable examples of an eponymous procedure is the Whipple's procedure, pioneered by the American surgeon Alan Whipple. This is otherwise known as a total pancreatic duodenectomy and is used to remove cancerous tumours from the head of the pancreas. It is the only potentially curative intervention for pancreatic cancer. However, due to the common presentation of advanced stage disease, only 15% of patients are candidates. Due to a shared blood supply, the duodenum, proximal jejunum, common bile duct, gallbladder, and sometimes part of the stomach are also removed, and some, but not all, of the surrounding lymph nodes. In total, the operation lasts approximately 5 to 7 hours. Other well-known eponymous procedures include the Bankart repair, Bayer's block, Colles gastroplasty, Nissen fundoplication, Halsted's operations, Moss surgery, and Wertheim's operation. While you should now have a basic understanding of how a given procedure can be classified and named, explaining some of the jargon surgeons use while operating is another thing. First of all, ligation means tying up a blood vessel, duct, or hollow tube. Irrigation refers to the flow of a solution, particularly saline, across or through a particular surface, body cavity, or wound for hydration, debris removal, or visualization. Reduction refers to the realignment of a specific body part to its original position, such as a dislocated shoulder, and anastomosis is a surgical technique that makes a connection between two hollow, fluid-carrying structures. These could be blood vessels or the gastrointestinal tract, for example, and is called a fistula when it arises naturally and abnormally. Cauterization describes burning a part of the body to cut or close it off in order to reduce bleeding, damage, or to remove harmful growths. Mobilization refers to making a particular structure movable by separating it from the surrounding structures for access or visualization. An incision is a surgical cut made through the skin, usually also through the subcutaneous tissue and muscle layers to access the surgical site. Palpation refers to the process of examining an internal organ or body part by touch to determine its size, shape, firmness, location, or connections. Reflection is the folding of a membrane, usually part of a cavity wall, over an organ. Retraction refers to the drawing back of an incision using retractors to gain access to the internal structures beneath. Dissection refers to the cutting apart or separation of tissues, which is slightly different from division, meaning separating into two or more parts. Transection can either refer to division by cutting transversely, or the process of making observations along a straight section of tissue in what is also colloquially known as running. Finally, evisceration is the removal of viscera from the abdominal cavity, and percussion is a similar examination process to palpation, except the surface is tapped sharply to determine its properties from the sound received. Whether you are a medical show addict or even a patient yourself, you should now have a better understanding of how the surgical team operates. Not only does effective communication increase operating efficiency and thus improve patient outcomes, but it also highlights one of the most crucial aspects of working in a multidisciplinary team: teamwork.